Welcome to My Matters with Dr. Michelle. Today I'm talking with Dana Lasenby, Executive Director and CEO of Oakland Community Health Network, about how we respond to trauma. Stay tuned for the conversation. We're going to take a quick break, share your thoughts on Facebook and Instagram at My Matters with Dr. Michelle. Welcome back to My Matters with Dr. Michelle, and welcome, Dana.
Thank you.
Glad to have you here.
Great.
So I do know a little bit about OCHN, but let's give us some background and also your role.
Okay. My name is Dana Lasenby. I am the CEO and Executive Director of Oakland Community Health Network, which is a governmental entity or quasi-governmental entity, and we're responsible for the mental health services for individuals who live in Oakland County. So what that means is that we serve individuals, probably more than 23,000 individuals a year with substance use disorder, mental health challenges, as well as individuals with intellectual and developmental disabilities. We also serve children who need services for autism. So it's very critical. We are what you would call the safety net for the community, which means we serve the most vulnerable people, and primarily the individuals who have Medicaid or who have no insurance. Although we will coordinate care for anybody who reaches out to us, our biggest service array is for people who are in need of those services who are uninsured and have Medicaid. So you're talking about individuals who have limited resources, who often need long-term care services and supports. So my role is, as the Executive Director and CEO, is really just to make sure that I'm probably the biggest advocate for those individuals we serve, and that's how I see myself, as an advocate and a servant leader of the organization. And so for me, it's really important to make sure that individuals have access to care and individuals have crisis services available when they need them.
And Dana, so you have, two major roles. How did you end up CEO and Executive Director?
Well, they sort of go hand in hand. I have one boss, which is the Board of Directors for our organization, which is appointed actually by the County Exec and the Board of Commissioners for Oakland County. And so that role does require me to report directly to a board, which is very unique in that they are appointed from the community. These are individuals that actually live and work and are a big part of Oakland County. So being a community mental health system means that we are based in that community and we assess the needs of the community. So the individuals that play a role in making decisions about the community are people on the board, and many of our board members are people served, as well as have family members and friends of people we serve. So that's really critical to involve the people in the delivery and the design of the system. So we're really making sure what are the needs and how do we address those needs.
And you serve people of all ages?
Yes, we start from 0 to 100.
To 100,
so no matter what age we are serving, and we have specialized services. So in the fact that we look at adults, we look at children, but more importantly, when you look at children and adults, I would say, if you think about it, none of us come single. None of us comes alone. So we really want to utilize those natural supports, and especially with children. When we look at the needs of children, we know we can help them in a single isolated situation, but really when they're returning back to their home and they're returning back to school or their community, we need to look at what's there for them and how are they going to utilize those skills and supports that we've provided to really make them helpful and positive when they return to be a part of that community, or when they're returning to their families because they've had some long-term care.
And what about, so when someone is coming to, when someone is seeking services, do they need a referral?
Absolutely
Or they can walk in?
They can walk in, and we really look at our system as a no wrong door. So anybody anywhere shows up and requests services, we will link them to those services.
How do you handle a situation where maybe a child, a teenager says, they're calling because they found out about you and all this great work you're doing, and they're saying, I would like to start therapy, but my parents are against it?
Right. Well, at the age of 15, children can actually sign themselves up for some services and supports. And interesting that you say that. Even prior to the tragedy in Oxford, we had a program that we were designing specifically for that reason, and it's called a school navigator, mental health navigator program. And so what we really wanted to do is make sure that teachers, students, families, administrators of schools, regardless of whether they have insurance or not, or if they have a commercial insurance, they could call us anytime and we would link them to service. Often what happens is the confusion is around insurance and how to navigate that, because you really don't think about it until you actually need the service and support. So with this program, the School Mental Health Navigator program, we will accept those calls from students themselves and help them to link to services or give them information on how to talk to their parents about the need for services and all sorts of things. So we want to make sure that there are no barriers to care. So if a 12-year-old calls us, for example, we're not going to leave that 12-year-old and say we can't talk to you. We are going to help them through the process on what the best way is to link them.
That is great information to have, because more and more kids are taking the initiative to seek out services, and I would say even more so than adults.
I think so too. I would agree with that a lot. I think when I think about the early 20s and young adults, they're talking more about their mental health. And I often say, you know, we think about COVID, and the whole pandemic was horrible, of course, and we're still going through it. But the one thing that I will say has been sort of a positive is that the attention to mental health and the need to be open and to say it's okay that I'm not okay. So I think that's the critical piece here, is that we do have young people seeking services, talking about it among themselves, and for that reason, we need to make sure that we're available to respond to those calls.
Wonderful. Dana, on that note, we're going to take a quick break. When we come back, I want to talk more about this Navigator program.
Okay.
Head over to @MyMatters with Dr. Michelle. We'll see you in a minute. Welcome back to My Matters with Dr. Michelle. So Dana, you were talking about this mental health navigator program. Yes. Can you talk more about that? Because that sounds like something that really speaks to what we're going through now when we're thinking about trauma related to school shootings and a host of other things.
Well, you know, it's important to talk about this because having access to care and the whole crisis piece of it is tied together. So making sure that people know where to call and when to call is critical. But the other piece is the students. And we knew even before some of the tragedies we've seen recently that students were struggling. They were isolated in the last 2 years. Some children thrive. Some students and young people thrive by being at home and really doing the electronic learning and all of that stuff. But other students were really, really struggling. They were isolated. They didn't get to see their friends, lack of communication. So what we did with the School Mental Health Navigator is we really wanted people who are specialized and are mental health clinicians that could talk to young people about how to access services, how to engage their family in part of that access to services. But also we heard a lot from parents and school administrators and teachers knowing that a child needed some kind of support and not really knowing how to go about it. So just giving them the words to use and then making sure that people are trained. There's so many trainings out there that are available. So this School Navigator is not just to connect people to mental health resources, but other resources in the community that they can use to help them get the support that they actually need.
How do you manage emergency versus non-emergency services? Because I find that the emergency services are always going to rank high on the list. We need to address this right now. But what about those non-emergencies?
Well, part of our role at OCHN is really community education too, and when to utilize emergency resources or crisis services, like we call them, versus urgent or routine care. And so I always think about it like we do on the medical side. We know that if you're not bleeding or unable to breathe, then you don't really want to go to an emergency room because the costs are high. But not just so for the cost, you don't want to have that service that really isn't needed. So we know a lot of times people will go to urgent care, meaning that they need same-day services or services within 24 hours. So when you look at how we provide services, that's really the mapping that we try to teach the community on, is that if you need to see somebody within 2 weeks or so, give us a call. We can help you make an appointment, and we can help you identify the right provider for that resource. If you need to talk to somebody within the 24 hours or the same day, like we do at a well child appointment or a sick child appointment, give us a call and we can identify a place you can go for same day. And if there is an emergency situation where someone is at risk for hurting themselves or hurting someone else, or they're just really out of touch with reality, which really puts them at risk, that's a crisis situation in which we have our crisis center in Pontiac, Michigan, where people can go 24/7.
You know, Dana, I find that in our field, we focus a lot on suicide prevention and suicidal ideation. But it seems to be less talk about homicidal ideation until there's a crisis.
Yes.
And I don't know if it's because we don't take it as seriously until something has happened, or we don't identify people who are homicidal as much as we do suicidal. What are you seeing with that?
I think it has to do a lot with the fact that suicidal thoughts are self, involving the person themselves. And then when you think about somebody that's homicidal, you're thinking about what they're doing to other people, which is more out and more talked about and more considered criminal. And so when we think about someone who has suicidal thoughts, we're knowing or understanding that they need help, right? And if we think about somebody who is trying to hurt others, we're automatically thinking of criminal. Something
let's
bad.
call the cops.
Let's call the police. And you know, I think that's an important point, in that how we screen and assess and support people who have those thoughts, and what do we do with it? We're getting so many calls from people who need help, not just because the person is thinking of self-harm, but also they're going out their way to harm others. And so where do we go to get those individuals the help that they need? And we are also a resource for that. And I think that's an important topic that we definitely need to start talking about, is that
a lot more.
it's a part of the mental health as well. And then there's a fine line from the law enforcement community. And our work with the law enforcement community really has helped us to address that in a way that law enforcement officers, through crisis intervention teams and training, actually can learn how to encounter and how to sort of work with an individual who is exhibiting behaviors where they're trying to hurt themselves or hurt someone else.
Yeah, I often ask the questions when I'm doing assessments, have you ever experienced homicidal or suicidal ideation? And it's always, I'm pretty prepared when they talk about the suicidal ideation. When I get to the homicidal ideation, I rarely have people who admit to it. But then when I do have someone who admits to it, I'm like, whoa, I asked this question, but I find myself, I wasn't really prepared for a yes response, like, yes, I've experienced this. So I do think that we need to focus a little bit more on that because of things that are happening right now. And then it's also, homicidal behavior could be a response to trauma.
Absolutely.
We want to make sure that we want to make sure you don't hurt yourself, but we need to make sure you don't hurt other people as well. I also had somebody tell me that, a loved one had attempted to take them to the hospital because they were talking about harming other people. And the front office staff told them they need to just call the police. And so it speak, and this was not that long ago. So this speaks to how we are just not prepared to talk about it. We're going to take a quick break. Head over to @MyMatters with Dr. Michelle. We'll see you in a minute. Welcome back to My Matters with Dr. Michelle. So Dana, I think we're in agreement about as far as how we respond to trauma and what we're prepared for, and maybe what we still need to
focus on,
brush up on a little bit more.
I think the training is critical, and I think being ready to respond when the issue exists. And I think that's why so many times those hotlines and who to call is so important, because when you're right in the midst of it, it's almost like you're trying to figure out what to do. So when you can train individuals and you can train the community in ways to recognize signs and symptoms that someone is distressed, I think that is maybe half the battle, so that we don't have people acting in a way that causes harm to themselves, their families, the community. And so our focus is always, how do we help communities recover, or how do we help communities to heal? So we've seen a lot of that in the last few months, in the last couple of years, I would say as well. And how do we go in and work collaboratively with communities? And so as a safety net organization, that's our job. We're boots on the ground going in, and we have mental health professionals that in many cases volunteer. So our role as the administrator and bringing our providers together and law enforcement and the schools and things of that nature together is really the best way that we have to help communities heal, help community address the issue without getting into the politics of it. It really is about getting and helping families heal.
And you know, and sometimes people don't even realize they're traumatized until they're faced with a situation that triggers them. And that's where coming in contact with the law becomes dangerous, because this person is going about their day, they have contact with the law, and there's something triggering. So this comprehensive approach that OCHN has is much needed.
Absolutely. What we found is working with the governmental entities, working with schools, working with our healthcare providers as well, in an integrated approach really is about looking at the whole person. So when you look at and pick out, oh, this is a mental health, or this is a physical health, or this is a person who has a housing issue, in the community mental health system, we look at all of that because we know that mental health, physical health, is one thing, but really looking at the social and economic resources that people have really plays a role in how they respond to stress. And if they don't have the resources, often their health and their mental health suffers.
Right, because when a kid comes in and they say, I'm depressed, you address that. But then what about, I'm hungry?
Right.
I'm going to be even more depressed if or I'm being abused at home.
Right. Or I'm watching one of my parents be abused, or my family, the homemaker, or the person who earns income lost their job. All of that plays a role. Or we don't have transportation, or we're living with a bunch of family members and one is extremely dysfunctional, or somebody who's engaged in a criminal activity in the home. And so we were raised to not talk about what happens in this house stays in this house. So now you have kids that are speaking out and being punished for it, but also they don't know who to talk to.
And Dana, Oakland Community Health Network also has partnerships that make all of this possible. Right?
Oakland Community Health Network has over 300 providers that we directly contract with. Outpatient providers, substance use disorder treatment providers, ABA providers are providers who treat and support children with autism, intellectual developmental disabilities. We also contract with residential providers and transportation providers, vocational providers. So the whole range of where a person is, we can address that. And those partnerships are really critical, not just those that we contract with, but the faith-based community has been a huge, huge partner for us in that, you know, many people listen to their spiritual leader.
Yes.
And so if their spiritual leader says it's okay to get treatment, it's okay to seek out, and maybe there's medication that can help you, people are more likely to listen from their spiritual leader that says it's okay without the stigma of it than those who won't. So working
They don't
with
feel guilty.
They don't feel guilty. They know that there's a reason why this resource is available, and they can point to that. So we've been able to reach a lot of the community through the faith-based community as well as through the schools, and really having people understand, you know, how their behavioral health impacts other areas of their lives, and the reverse, how these other resources that we talk about that are limited can impact their mental health.
Wonderful. And Dana, as we wrap up, are there any needs that the agency has right now?
Absolutely. We're always looking at ways to, well, actually every year we do an annual needs assessment, and we know what those needs are. but we really are focused on making sure that people know how to access services, and we are expanding our crisis services, as we talked about earlier, with children. For crisis services with children, we currently have a small unit at the Resource and Crisis Center in Pontiac. We're actually expanding that through a grant from SAMHSA to build 10 additional beds. So what that will do is really support families who have children that are in crisis instead of waiting in the ED for a very long time. They can actually come to our Children's Crisis Center and receive services immediately as opposed to waiting. So that's due to open in late August. So we're really excited about having that as an option for families.
All right. And tell us how we can find you.
Well, we are available 24/7. We have a crisis line, and I'm believing the number is put up for us.
Yes.
Great. And then also, we are located in Troy, where we have access workers working throughout the community, but primarily in Pontiac. So that information is also available.
Wonderful. This is a much needed service that you're providing, and I want to thank you for coming in. I've learned so much through you today.
Thank you.
Yeah, so we're going to take a quick break. Share your thoughts on Facebook and Instagram at My Matters with Dr. Michelle. Thank you for watching today. Needing a break is not a sign of weakness. Even the most emotionally resilient person gets overwhelmed. So make time to just chill. Head over to My Matters with Dr. Michelle to share your thoughts about today's episode and more. Improve your mental health, improve your life. See you next week.